So if we just do a quick overview of the orbit and the eyelid, we have the 7 bones of the orbit that will make up our orbital margin, as well as the bones of the orbit. Everything that is not the eyeball, the muscles, neurovascular bundle will be the orbital fat. The orbit pyramid has an apex as shown on the left. The apex is in the optic canal, whereas the base is outside the orbital margin that's made up of the other bones. We have two walls of the eye, as you can see here in black. So we have the medial wall, which is parallel to each other, and then we have the lateral wall that form this 90-degree angle. Both of these will give us a orbital axis, which is at 23 degree, whereas in red we have our visual axis, which is parallel to each other. So visual axis is parallel, just like the medial wall. Then we go talking about what is surrounding the orbit. So the roof of the orbit up top, we will have our frontal sinus. Medial to the orbit, we will have the ethmoidal sinus in the nose, and then the floor, we will have our maxillary sinus. And that's important, is that if you get a blowout fracture due to the intra-orbital pressure that increases, our maxillary sinus will be damaged. Then we talk about the bones that surround the eye. Here we have the, in the picture on the left, we have the margins that are shown right here. We have the orbital margin that is made up of the frontal maxillary zygomatic. We have the superior wall, which is from the which is with the lesser wing of the sphenoid bone right here, and the frontal bone. Orbital plate of the frontal bone. We have the medial wall made up of the sphenoid, ethmoid, lacrimal bone. The inferior wall, the bottom, is made up of the orbital surface of the maxilla, as well as the zygomatic and the palatine process, orbital process of the palatine bone. And then the lateral wall, of course, once again, is the greater wing of the sphenoid and the frontal process of the zygomatic bone. Next, we talk about the eyelid itself. The eyelid is composed of the orbital septum, which is a sheet of a membranous sheet that is continuous with the periosteum. It drapes and attaches to the orbital rim. The rim has a superior and an inferior tarsal plates. So think of those like where the eyelashes are attached. And we have a muscle, levator palpebrae superioris, that is attached to the superior tarsal plate, and with the help of that, we're able to open the eyelid. Whereas closing the eyelid is facial expression, orbicularis oculi muscle, innervated by facial nerve. So normal opening of the eyelid is by levator palpebrae by CN3. Extreme opening of the eye due to sympathetics is by cranial nerve number 3. And then we have a Horner syndrome that can be due to loss of sympathetics. Here on the left, you can see we have the superior tarsal plate here in purple that's drawn with the gland that releases these sebaceous fluids to keep the eyes basically kind of waterproof, or to keep the water. We also have levator palpebrae muscle and superior tarsal, which are sympathetics, that are on the top on the superior tarsal plate. We talked about the blood vessels. We have 3 blood vessels to the eyelid: ophthalmic, which is came through internal carotid, and then by external carotid we have the facial and superficial temporal arteries. And those are important because if we have a blood flow from the inside and the outside through the internal and external carotid. Veins, like the face, are once again valveless, so we have the superior, inferior ophthalmic veins with the help of angular veins, and they all can drain into the cavernous sinus. Then we have the lacrimal gland. Lacrimal gland is situated superior lateral to the eye, and it starts with the lacrimal gland being number 1. Lacrimal gland will basically create the tears. They will go through the conjunctival fornix, go across the eyelid into the canoniculi, into the lacrimal sac, drain down to the nasolacrimal duct, into the nasal cavity. And then we have 2 types of conjunctiva, which is basically lining. we have the palpebral, which is the inner, and then we have the bulbar, which is the outer. So I will show that real quick. So going back here, just imagine we have our lacrimal sac gland right here, and the lacrimal gland will create the tears. They will go into the fornix, go across the eyelid, into the canoniculi, into the sac, into the nasal cavity. And then here we have just trying to show the tarsal gland and the tarsal plate in purple. We have some labiator palpebrae muscles that can attach to that with the superior tarsal muscles that will open the eyelid. But here in red, as you can see on the inside of the eyelid, we have the palpebral conjunctiva. In blue, we will have this U-turn of conjunctival fornix, and then in the orange, we can have our bulbar conjunctiva that is over the lens itself. So once again, the bulbar here, we have the blue, which is fornix, and the red, which is the palpebral. If we talk about the eye itself, we have three layers. We have the external fibrous layer, the middle vascular layer, and the internal retina. Going into the eye, we have our outer right here, number 1, sclera, and the cornea. And then inside we have the iris. We have the ciliary body, and then the choroid. And you can see the iris gives us the color. This one is in red, and it's made up of the sphincter pupillae that give us parasympathetics, dilators by sympathetics that will open the eyelid. Then we have the iris that provides us with color. Like I said, we have the ciliary body, which changes the lens, the shape of the lens through parasympathetics. And then we have some ciliary muscle that is attached to the lens, and the lens splits into the posterior, which is a vitreous humor, and everything in front of the lens is anterior. But the anterior can be split into two, the anterior chamber and the posterior chamber. We know in the posterior chamber we're making the aqueous humor right here, which is then transferred through the pupillae into the anterior chamber. If we keep going, we will just talk about some muscles. We know the extraocular muscles, LR6, SO4, 3. So LR6, lateral rectus, is innervated by cranial 6, superior oblique by 4, everything else by 3. Lateral rectus is doing abduction, pulling away, innervated by abduction. Medial rectus does adduction, is innervated by cranial 3, and the other superior oblique is innervated by the cranial 4th, trochlear. So right here, trochlear would be C and 4, and 6, and everything else should be cranial nerve number 3. Innervation to the eye, we can have dilation of the eye or constriction of the eyelid. Dilation of the eyelid is with the help of pupillar dilator, smooth muscles, which start from the IMLCC, go through superior cervical ganglion, hitchhike on the internal carotid plexus with the short ciliary nerve, and contracts the pupillar dilator. Whereas parasympathetics constrict the pupillary constrictor muscles with the help of ciliary muscle, and the innervation is from the nucleus of Edinor-Westphal, goes to the ciliary ganglion and the orbit, and to the short ciliary nerve, and then to those muscles to constrict.